First, thank you, Dr. Suda, Dr. Evans, the SAGES crew for inviting me, and thank you all for showing up. I appreciate you being here. But I'm gonna just have to bring up a couple points of contention here. So first of all, we have to acknowledge that during a pandemic, this is a rapidly changing environment. The situation can change even hour by hour, so the rules have to change. We need enough resources to take care of the sick, but also a reasonable enough cushion so that we can flex if the cases surge or escalate. So if we're running at maximum resource utilization, when those case escalations occur, we're gonna have a major crisis. It's gonna be compounded. Make no mistake, this is about saving lives, and this is a humanitarian crisis. This requires triage. We have to focus on saving lives. And Dr. Campbell, as a trauma surgeon, is well aware of those triage principles. Immediate need for care to save life is number one, then urgent care, then delayed care, then expectant care. We need to consider the impact on saving lives and the urgency of treatment, but also the impact on functional status and disability. Even with Dr. Campbell's example on cancer, we all know cancer is not the same. Some cancers are slow, they're indolent, growing very slow. They can treat medically initially, delay surgical treatment for later. But some cancers present with acute, life-threatening complications, acute bleeding, obstruction. Those need to be taken care of emergently. I agree with Dr. Campbell that we need to think about exposure and avoid unnecessary exposure of our physicians, our nurses, our staff, patients as well. So if we're gonna do people who have medically necessary needs but less urgent, we need to prioritize patients who are vaccinated so that we can lessen the exposure risk. And then I'm gonna go right into my rebuttal. Okay, so my opponent did have a few good points. I'll give him a couple, okay? So if we turn off the entire non-emergent elective healthcare system, what happens is you can get a delayed effect where the system can become overloaded later by people who delayed their care. There's a downstream ripple effect, and we're experiencing that right now from the first wave of the pandemic. So maintaining some flow of non-emergent procedures can be helpful, but we just can't run at maximum capacity with no room to surge. So that means these decisions have to be made on a local basis based on case volumes, resource utilization. Patients who have prepared for surgery for a long time, like in my field in bariatric surgery, they've prepared weeks, months for that surgery. And if they can be very emotionally impacted or even harmed by a short notice cancellation. But guess what? The volumes of the sick from the pandemic can increase rapidly. Within 48 hours, you can have a big surge of cases, which can cause a very short notice cancellation, even the morning of surgery. In the current phase of the pandemic, I agree, we have adequate PPE, we can control much of the exposure risk, but what are we short of? Human resources, okay? Facility resources. Guess what? My hospital, and I'm guessing a lot of yours, are already full with all those who delayed care, and now there are much higher acuity patients because they delayed their care. They're super sick. There's no room for these pandemic patients. But more importantly, we have a major nursing, physician, provider, staff shortage. Many people have left the healthcare field. Those that remain are wounded, they're exhausted. They can no longer go that extra mile because they've already been another extra mile and another and another, and they just don't have any extra miles left. So we have to really think about how we can have flex in the system. We can't triage people to appropriate facilities because essentially we're gonna crush those places. They'll financially go over, their people are exhausted. It becomes the haves and the have-nots in healthcare of who's gonna survive. So we can't do that. The only place where we can flex is really elective surgery. Thank you, I won already.
Campbell, and pleasure to be here today to talk about the great debate at SAGES against elective surgery should be halted when pandemic cases are rising. In fact, we should continue. I'm a professor of surgery at the University of California, San Francisco, and I work at San Francisco General Hospital. I have no disclosures today with regards to this, other than I've been through COVID like everyone else has. So, elective surgery should not be canceled, Patients are getting sick and dying because they're not getting their elective cancer surgery or urgent emergency general surgery. We must maintain quality and keep treating patients as much as possible. Now, advanced planning can really help make sure that the COVID patients are cared for when cases spike, but with proper resource allocations, we can really do what necessary to save lives and to take care of the COVID patients. So the two are not mutually exclusive. So this time around, we have adequate PPE, not like when things started. The first start, we were scarce. We were not able to use things, and we actually had to reuse things a lot. Now we can throw things out when we get them because there's adequate PPE in place. We have protocols in place on how to do it safely. We have evacuators in the OR, negative pressure rooms, and make sure everything is safe, because the last thing we want to do is really expose our providers during this course, and only allow essential personnel in during intubations. As some of the emergency general surgery and trauma surgery I do, sometimes I don't know the COVID status, and I have to make sure that I protect everyone. So everyone needs to have an N95 with proper eye protection during the course of intubations and when we're doing high-risk procedures on the trachea and the airway. So we have to triage patients to appropriate centers that allow other centers to continue. Only when resources become scarce do we really need to change our approach. Our institutions, we canceled cases, but the second wave, we worked around it, and we were able to make sure we take care of everybody in an appropriate fashion. So it's important that the patients get cared for, even if they do not have COVID. So in conclusion, we do not need to stop providing essential laparoscopic care. With proper planning, we can alleviate any of the surge issues. Now, PPE is now adequate, and all patients can be cared for with precautions in place. And we need to test all our patients. We get rapid COVIDs on people. We also need to get PCRs to make sure we have everything so appropriately diagnosed. So knowing who has COVID and who doesn't have COVID is essential. So to summarize things from this point of view, number one is that we can provide for everybody. We can do it safely. Proper planning is really the key, essential. You must make sure the entire hospital is on the same page. Now, currently, things are quite busy down in the South. Now, that's a situation that is a little bit different in that when there's not any room for anybody, you have to move into a disaster footing. In that case, you have to actually change the goals of what's going on. So then that's a resource utilization situation. So making sure you have proper resources, making sure resources are allocated, and the physicians and surgeons must work with the hospital leadership to make sure that we successfully do it. But in my mind, we need to continue doing perfect and appropriate care for our patients. Thank you very much, and it's really great to be here at SAGES, even though it is remotely. Thank you so much.